video for GIT. So I've made a video on functional versus pathological constipation for peds. I made a video on biliary cysts for peds. Now I'm making another video which is gastric bypass. Okay, so over here guys, we're gonna have the ROX and Y gastric bypass. So what's going on over here? So basically it's like a Y shape, okay? So it's like a Y shape, like this Y. And essentially what happens is the dietary nutritions, they come over here from the top, and we basically bypass the whole stomach system and the biliary system, okay? So we're not going to get a lot of digestion. We're just going to be, everything's going to go through quick. So we call this basically a stomal or anastomotic stenosis, and it's caused by the progressive narrowing of the gastrogenal anastomosis that leads to obstruction of the gastric pouch outflow. This complication usually occurs within the first year after surgery, and likely due to local tissue ischemia and necrosis. So it can be due to ischemia and ulceration. The patient will have progressive symptoms, so they'll have nausea, postprandial vomiting, and they'll have reflux and dysphagia. So as you guys can imagine, that if there's going to be some stenosis over here, so we can imagine this is the jejunal anastomosis. So if there's going to be some stenosis over here, which is mean the gastrojejunal, we're going to be getting the food's going to kind of go upwards. We're going to get postprandial vomiting. We're going to be having nausea. We're going to have reflux, and we can't be taking food down, so we're going to be a dysphagia. Okay, so what we want to do is do an endoscopy. That's pretty much the main options we have. We have, of course, CT, X-ray, and we can do ultrasound. But the main thing, guys, it's going to be doing an endoscopy. Okay, so now once we're going to be doing a endoscopy, during which a balloon can be a dilation balloon can be performed to kind of open up the narrowing, and sometimes people may even need some surgical revision. Okay, now I want to come. Another problem is that we can get a cholelithiasis, but I wanna come to that in a moment. So we can see complication ROX and Y early in leaks. So early, guys, as we spoke about this anastomosis leak. Okay, so this anastomosis over here between the gastro and the jejunal, this anastomosis, there could be some leakage. And then we can also have, for instance, maybe some sort of bowel ischemia or any diffuse abdominal pain, and that's because during surgery, and I've spoken about this in my videos where I spoke about the acute kidney injury. After surgery, we're damaging vessels, so we're going to be having low volume in our body. So that's going to be here during after surgery manipulation of mesenteric vessels, and that compromises the blood supply. And then we can have also other complications as anastomotic stricture. So it's kind of opposite to what we spoke about a leak. So we spoke about a leak, now we're going to have strictures. Then we can have with her marginal ulcers, so an anatomic abdominal pain, bleeding, periosmotic anastomotic perforations. So that's going to be over here marginal bleeding. So there's going to be increased amount of gastric exposure, the increased acid exposure, ROX Y gastric bypass. The pouch is usually smaller and may produce acid. The alterations in anatomy can cause increased exposure of the small intestine segment at the anastomosis site due to gastric secretions, including acid bile, and can lead to mucosal infiltration, ulcer formation. So we can get increased amount of acid. That's because the gastric pouch is now smaller and may produce acid, and the alterations in anatomy causes increased exposure to the the things we eat, so that can cause ulcerations. We can get cholelithiasis, guys. We're gonna have alterations in the bile composition, because now we're getting change in cholesterol metabolism. There's a lot of weight loss. Cholesterol is going to get supersaturated in bile, and that can promote gallbladder precipitation. There's maybe also some gallbladder stasis. That's because the cholecystic kinin is secreted from the duodenum and jejunum, and this is going to be response to enteral and stimulates the gallbladder contraction. And ROX and Y, of course, the duodenum is bypassed, so there's going to be decreased amount of cholecystic kinin, and that's going to be causing there to be a lot of gallbladder stasis, and that can possibly lead to some sort of gallstones, for instance. We can also have, for example, dumping syndrome over here. Dumping syndrome essentially means that there's going to be rapid emptying. So there's going to be a significant change in the blood flow as the body can compensate to the increased intestinal volume and activity. So we're going to be having vasomotor because we're having there's going to be disturbance of the fluid. So you can imagine something is getting dumped. So That's going to cause cramping pain. Guys, they were asking one time, like, someone comes with a 45-year-old female. She has sudden onset abdominal pain after dinner, and she had severe pain in the upper right side of the abdomen. So she nausea, vomiting, radiates to the right shoulder, and she had 15 kg weight loss after 5 months of Rox and Y. What is the cause? That's weight loss, guys. As we spoke about, that we're gonna be having the duodenum out of the picture. So our cholecystokinin is now even out of the picture. So what happens is that we're going to be getting we're not be contracting a gallbladder, so that's going to be causing these problems to occur. So guys, I'm just going to quickly recap this whole thing over here with regards to Rox and Y, and I want you guys to comment down the complications in the comment section. I want you guys to comment it, because active recall is the best way to kind of think about these things. So guys, we're going to have early complication, which is going to be any sort of leakage, and we can have, of course, damage to the vessels, which can lead to bleeding. Second is going to be, after a long time, there can be inflammation, so you get strictures, dumping syndrome, so it can all go out. We can get, marginal ulcers, because, we're getting a lot of toxics, and we can get gallstone. That's because we remove duodenum, we're decreasing cholecystokin and less contraction of gallbladder. Guys, I hope you found this video useful. Make sure to comment down all the complications. This is going to be good active recall, okay? Thank you guys for watching, and I hope to see you guys next time.